Think we'd like to get started? Can I get a motion to reconvene into open, please? Councillor Foxton, second by Councillor Jowett. Yes, we do. We just have a quorum. All in favor? Are there any declarations of pecuniary interest? Seeing none, we're going to move into presentations, and thank you, Dr. Mather, for your patience.
If I may, Madam Chair.
Oh, excuse me, I think
Mr. Bartholomew.
Mr. Bartholomew-Saunders would like to make.
Thank you, Madam Chair. This is Dr. Mather is with us today because this is our annual report from the medical director of Sunnyside Home. I think it's interesting to note that a couple of things about Dr. Mather. I believe, is this 20 years, Fred?
This will be the 20th time I've given this report. Yes.
So there we are, 20 times that we've had Dr. Mather here as reporting, which means that we've been fortunate enough to have him for 20 years as our medical director, and we truly do value his input. It's important to note also that Dr. Mather is a sector lead for the province in older adult care, and we're very fortunate to have his expertise on that front as well. So thank you very much, Dr. Mather, and over to you.
Required to submit each year quality improvement plan, and I'll highlight here three items from our quality improvement plan. Transfers of care, which can also be interpreted as emergency department avoidance. Service excellent, and an example of that is what's now referred to as our Still Me project, originally taking the principles of dementiability, and then falls, which is a perennial topic that I mentioned. Other quality indicators pertaining to safe and effective care is antipsychotic use. I'll also mention my involvement in the long-term care inquiry, which was last year. We had the public hearings followed by consultation sessions, and some ideas as to what lies in the year ahead, because there'll be even more to report if I come back here for the 21st time. So the transfers of care is given special attention. It's a quality indicator, and it's part of the current government's plan to reduce hallway or eliminate hallway health care. The way in which long-term care contributes to reducing hallway health care is to, on one hand, improve inflow, and that's increasing capacity, and there has been that promise of 15,000 new long-term care beds in the province in the next 5 years, of which 7,000 and some have already been assigned. But the other aspect is to manage the outflow of people coming out of long-term care, in particular transfers to our emergency departments and admissions to hospital, especially when the best interest and care of the individual can be met in the facility itself. It was either a year or two ago that I presented the long-term care choosing wisely recommendations of the Long-Term Care Medical Directors Association of Canada. And the first recommendation is don't send the frail resident of a nursing home to the hospital unless their urgent comfort and medical needs cannot be met in their own care home. And the data shows that probably there are far more transfers that occur than need to occur. And the risks to the individuals, the frail elderly that we look after, are increased risk of delirium, the problem with hospital-acquired infections that require special attention when they return, a lack of sleep, and lack of sensitivity, which leads to loss of muscle mass and increase the risk of falls. From the Choosing Wisely recommendation, a clear understanding of a patient's goals must be established, taking into account the current health status, values, and preferences. This will reduce the likelihood of inappropriate transfers. So how do we do? Fortunately that our LHIN, the Waterloo-Wellington LHIN, has always been below the provincial average, and Sunnyside Home has tended to be below the province and the LHIN. Our home is the blue line there, which measures avoidable transfers to the emergency department. The red line is the LHIN, and the green line is the provincial average. We've also, over the last 3 years now, had the benefit of a nurse practitioner who attends the home 2 days a week, and she is very helpful in terms of avoiding unnecessary transfers, talking to families, and presenting options of care. And you can see on this graph where Carrie here started working in the nurse-led outreach program and the effect it's had on reducing transfers with the understandable variability between the quarters. And this is where we're at over the last year, showing a fairly consistent pattern here. The Dementia Ability Project is an example of person-centered care. It's now taking the principles of the Butterfly program that has been in the media in different homes in Peel region. The whole idea is to make the homes, the long-term care homes where people live, more like a home, a place that welcomes family and friends. And so, especially in our two dementia units, Buttonworks and Laurel Creek, we now see brighter colors and an environment that connects with the individual's past and interests. For example, this gentleman in the workshop in the garage, or a place where the women can enjoy the benefits of a nursery and dolls to hold, which is very helpful in consoling and engaging individuals with dementia. So falls are common, and falls have always been an issue, especially since of the 1/10 of the beds at Sunnyside Home is the convalescent care unit. The convalescent care program is a program with a maximum stay of 90 days where we have individuals come to us mainly from the hospital after they've been treated for a fracture or often more than one fracture, and they need time to heal and to be rehabilitated. The quality indicator for falls is falls that occur within 30 days in which the measurement is made. So we tend to have a high fall rate because a lot of the people we're looking after in that unit in particular have had a fall before they get admitted to the home. The very positive thing about the convalescent care program is that although these are people who are failing and falling at home, 80% of the people who are admitted return to their own homes or to a retirement home after completion of the program. Now, I present this graph, which is from Health Quality Ontario, looking at the provincial average of reportable falls in all long-term care homes. The target is 9%, and that's what homes are expected to aim for. But if you look at the trend over the last 8 years, there's a gradual increase in the incidence of reportable falls. This only reflects, in my opinion, the increased frailty of the individuals that we're looking at, that it goes along with the fact that we're admitting people who are more acute, closer to the end of life, which is also manifest by the shorter lengths of stay. This, on the other hand, here's a quality indicator that has been going down over the same period of time, and that's the percentage of individuals who are receiving antipsychotic medication without an indication. And the indications are schizophrenia, Huntington's disease, delusions, and hallucinations. And there are valid indications outside of that range of criteria, although it is a quality indicator that gets some attention because antipsychotics may be useful to control symptoms such as agitation and aggression in dementia, but also has unwanted side effects that include confusion, high risk of falls, and increase of death from stroke. So I mentioned the long-term care inquiry in my introduction, and I was pleased to be, as president of the Ontario Long-Term Care Clinicians, a participant in the long-term care inquiry. This is from June 5th when the inquiry opened, giving an opening statement. And it was a long process. It's been 2 years now, almost 2 years since a particular nurse was charged with the murder of 8 long-term care residents and attempted murder of 4 others and 2 accounts of aggravated assaults. There was then an order in council from Cabinet to order the public inquiry to look into what the order in council described as systemic failings of the long-term care system. My involvement began in December 2017 to apply for participation in the public hearings. And prior to the beginning of the public hearings last June, there were several meetings, most of them teleconference. And the public hearings went from June to the end of September, a total of 40 days in total sitting. A lot of us who weren't actively involved all the time could follow them by the daily webcast as they were live streamed. After the public hearings, there's been consultation sessions, concluding in this January past with plenary sessions, and the final report of the Justice Eileen Galisa's inquiry will come out on July 31st this year. So there's the timeline of the very unfortunate story of 8 deaths of individuals in long-term care and the other offenses which were committed. At the throughout the hearings, and I take this from an article which Heather Malik had in the Toronto Star last June as to where the levels of failure in the inquiry were identified, shared by the Nurses Union, the Nurse Regulator, the College of Nurses of Ontario, the Long-Term Care Inspection Branch, the employers, in particular the one employer where 7 of the 8 murders occurred, the Office of the Chief Coroner of Ontario, and there were individuals such as this nurse pastor who she actually confessed her actions to, but no one really believed what was happening. So there was a lot of exposure of issues in long-term care over the course of the public hearings, and consultations began in the fall, focusing not so much on long-term care, interestingly, but the phenomenon of the healthcare serial killer and how they need to be detected and deterred. Further focus of the consultations included death investigations in long-term care and medication management. So after the plenary sessions in January, here are some of my takeaway points, and I can't say for sure what's going to be in the final report of Justice Galisa when it comes out in July, but these are things that can be anticipated. That there is recognition of the phenomenon of the health care serial killer, which is present not just in the long-term care setting, but in the hospital and the home care setting. And so the recommendations will go far beyond long-term care. the message was that long-term care is overregulated and the overregulation and the punitive aspects of long-term care affects the quality of staffing and recruiting in long-term care. Possibly recommendations about a dedicated coterie of coroners for long-term care investigations and related deaths. And one thing that I think really will be appealing to a lot of us, that there needs to be more government support for long-term care training and education. And one thing that Justice Scalise passionately recommended for us who are participants, and I know she will when she releases her report, is that the inquiry will not be connected with the name of the nurse who perpetuated the crime. It gives her an undue influence. There was evidence presented at the inquiry itself that her crimes were a copycat crime, and we don't want to give her that status, much the same as when there were the mosque killings in New Zealand last month. The Prime Minister of New Zealand refused to use the perpetrator's name. So the Ordering Council addressed systemic failings in Ontario's long-term care home system. I think that out of the tragedy, there'll be a more positive wording used in the final report, where you will hear terms such as there's a need to restore public confidence in the long-term care system and an opportunity for building excellence and capacity in long-term care. One change in medical staff at Sunnyside this year is Dr. Kent McKinnon, who's been the doctor on the Riverside home for about the last dozen years, has retired from Sunnyside home. He does carry on still in his office practice, and Dr. Patricia Froese has taken over his unit. And so I think Trish is probably the first millennial doctor we've had on staff at Sunnyside. We have 4 physicians there, myself, Dr. Jonathan Pete, Dr. Tom Irvin, and now Dr. Froese, and I think we have each decade covered as a result. So that makes for a good progression along the way. A few final points in my involvement. There is going to be changes in the public reporting of long-term care homes inspections. They're looking at using a tool that's presently used called the Long-Term Care Performance Assessment Tool that will revamp the website where people can get public reporting from the inspections in long-term care home. They're currently available but very difficult to read. And the other big unknown is what the impact of Bill 74, the People's Health Care Act, will have on long-term care. As you can see that in this brief presentation, I've referred to data from the LHIN and from Health Quality Ontario as a way to measure and assess quality in long-term care, and both of those agencies are probably undergoing change. Well, we know the LHINs are for sure, so it'll be interesting to see how things develop in the next year ahead. So thank you for your time, and I'll answer any questions if there's any. Okay.
Thank you, Chair Clark. I wasn't going to press the button because I thought we were still offline. Thank you very much for your fulsome report. Can I now tell everybody, they say, have I had my annual checkup? I can say, yes, I've had it, the 20th one in a row.
Okay, yes, yeah.
I found your insights into the inquiry fascinating. Yeah. And one of the lines that it sounded like was your personal takeaway was the fact that long-term care is overregulated and punitive. Yep. And yet I remember during the hearings hearing that the nurses union in particular were saying that they wanted nurses to report medication and when they hadn't prescribed it correctly. So they sort of didn't turn a blind eye exactly, but there was a tolerance. And I'm just wondering how you square that sort of situation, which appeared to lead to some of the the demise of some of the patients when they were administered insulin inappropriately in that statement.
The one home that was involved was a home that had several inspections. There's different forms of mandatory inspections. There's the RQI, the resident quality inspection that is mandatory each week. At Sunnyside, for example, we would have, say, about 3 inspectors come in the home for a period of about 2 weeks' time. It's very upsetting. It's very threatening, and there's not a lot of discourse and back and forth, and we never know for sure what that report is going to show. So there's the RQI inspection, there's the complaints inspection, that if anybody makes a complaint, there's an inspection that follows from it, and there's a critical incident inspection as well. So there's all these inspections, and the outcomes are that a home is punished, they're given written notification or that, but not enough back and forth on how we can improve our care. So how it relates to the inquiry is that home involved had a number of inspections, but it probably did not do anything to actually identify the risks that were present for the residents.
Thank you very much.
Okay. Okay.
About some of the stuff that's coming from the province our way, and some councillors were asking for some good news. We didn't get any from them, but nice that we got some from you. I think I can speak for council when I say that we're really proud of Sunnyside, and recently got some nice media, which was a good thing to see. So thank you.
Thank you. My pleasure. Bye.
All right, we have no delegations. Is there a request to remove items from the consent agenda? Seeing none, do I have a motion to approve items or receive for information? Councillor Lorenz, seconded by Councillor Erb. All in favor? Right. On to the regular agenda. And we have a presentation scheduled. Michael Park. Oh, there's Michael. I saw you, and then you left, then you came back, and then you left again. Michael Parkinson presenting on Youth in Waterloo Region on issues of substance use, a report.
So much. Good afternoon, Chair Clark and members of council. Thank you for the opportunity to share the latest report from the Crime Prevention Council entitled Conversations of Substance Use in Waterloo Region on issues of substance use. That's so helpful. There's a short presentation to go along with it, but suffice to say, none of the contents of the report would have been possible without the brave young neighbors in our community who came out to share their experiences with using substances in Waterloo Region, and then some, and of course the agencies and who help facilitate those kinds of opportunities. The purpose of the report is really to inform the development of the Waterloo Region Youth Engagement Strategy. It's a strategy that forms part of the Regional Strategic Plan as part of the opioid response strategy. And secondly, really to hear from those voices whom we don't hear from often enough. That is young people who are using drugs, including alcohol, at a time when fatalities from opioid-related poisoning continues to escalate, continues to set new records right across the country, and disproportionately affect those farthest from opportunity, primarily those with low or no income. Second impetus for the report, the context in which we operate, is really around the legalization and regulation of cannabis. And in the fall, we brought forward a report called An Ounce of Prevention that highlighted concerns about the high rates of cannabis use locally and across the province compared to our European counterparts. And that report, if you're interested, is on our website. But it speaks to the near absence of conversation around cannabis legalization related to upstream prevention, the real efforts to prevent or delay the onset of cannabis use. And don't get me going on the funding part of it. So to that end, we spoke to 33 youth from across Waterloo region who are, often labeled at risk, marginalized, disengaged. We performed a thematic analysis and really came up with sort of three broad themes. The social environment is one that, for those of you who had the privilege of hearing Dr. Christensen about this time last year from Iceland, is really around the social environment, home, at school, neighborhoods, those kind of environments where participants felt those environments were working against them, that they worked against prevention and they worked against the mitigation of harm. The second theme was really around social and structural stigma and sometimes outright discrimination. So social stigma refers to, those comments from neighbors and in community. Structural stigma refers more to the kinds of services that are withheld or not offered from agencies, from service providers, from governments. And the risk, of course, is that people on the margins tend to internalize that and come to expect less service than those of us around this table might enjoy. Third theme relates to mental health and well-being, particularly in terms of service system that struggles to meet the needs of people requiring support. And all of this sort of reminds me of a gentleman by the name of Dr. Julian Tudor Hart, who wrote in The Lancet in 1971 and proposed something called the inverse care theory. And I saw it at play when I worked in direct service, and what Dr. Hart was saying was that those most in need of healthcare services are least likely to receive them. We're pretty good at serving the top of the bell curve, but the edges, not so much. So what we found is absolutely consistent with the existing evidence, both locally and farther afield. It's consistent with the policy direction from any number of policy documents that have been developed over the years, from the Ottawa Charter for Health Promotion in 1986 to there's a YW report down there, the 5-volume, 1,497-page Roots of Youth Violence report from the province, and then more recent reports from the Chief Medical Officers of Health in Ontario and in Canada at the Public Health Agency of Canada. So we'll continue to build out the Waterloo Region Youth Engagement Strategy. We'll incorporate the excellent work that has preceded us, incorporate conversations, reports. The funding environment, as you know, is what it is, and that continues to be a struggle on our end, but we're grateful for your support. And again, thank you for the opportunity to share that report. If there's any questions or comments, I'd be happy to entertain them.
Councillor Foxton.
Thank you. I found the report amazing. I made my family sit down while I read out what the young people said. I think we have to publicize this more. There's a disconnect between what we truly understand and what we perceive to understand and the realities. And I could so easily see our young people falling into these situations. Not just our young people, I think people in general, who, some of them were saying that they just needed it to sort of calm down, to get sort of, because their life seemed chaotic and out of control. And I think a lot of people feel that way, and I think we have to deal with the issue before we can make a difference. But this really highlighted it so well. They spoke so eloquently. You should be very proud of them. So thank you.
Thank you.
I see no other questions. Thank you, Michael.
Thank you so much.
All right. Our next item on the agenda is Consumption and Treatment Services Interim Site Update. You may recall that at our last committee meeting, Councillor Vrvanovich requested that staff look into the opportunities to bring a temporary site to the region more quickly than otherwise. And I guess this is an update on where we are with that. Did you want to speak to that, Dr. Way?
Thank you, Chair Clark. So this report provides Council with an update on where we are in the process, the things that we have done, as well as what we're planning to work on next. And we are planning to bring forward a subsequent update to the next Community Services Committee meeting.
On May 28th.
Yes, that's correct.
Any questions? Seeing none, thank you very much. Municipal accommodation tax. Who's going to speak to that? It's in the report, but does anyone have any questions? All right. Is that a motion? Yes. Okay. Then Chair Redmond is moving. Is there a seconder? Councillor Jaworski, all in favor? That was easy. Oh, all opposed? Any opposed? Councillor Harris, did you want to speak to that, or did you want to speak to that? Okay. That's all right. Okay. Council enquiries and requests for information. Councillor Jowett.
Thank you through the chair to Dr. Wangel. I'm asking about the report that's sitting there for spring. It just says spring. Can you tell me whether that's coming May 8th or May 28th and whether it will be inclusive of Narcan distribution from the region or public health?
Yes, we are still working on that report and are planning to bring that to committee as soon as we can. Trying to balance the work with the consumption sites, but definitely continuing to work on that and intend to bring forward a report as soon as we can.
So we can't get
in the
a
next
date.
couple of months.
So May or June, not May.
That's correct.
Okay,
May or
thanks.
June.
I believe
Thank you.
we've established that spring ends June 21st.
Okay, so it's
Thank you.
official. I'll tell that to the hundreds of people that keep emailing me for it. Thanks.
All right, is there any other business? Seeing none, the next meeting, Tuesday, May 28th, a slight departure from our schedule. And do I have a motion to adjourn? Councillor Foxton. Do I need a seconder? That would be Councillor Armstrong. All in favor? Excellent. We're done. Rapid Transit Steering Committee meeting. That was an uneventful one. I'm used to being here for 7 hours.